Hello, everyone, and welcome to tonight's equine educational webinar. Thank you for joining us for another topic in the VMC Animal Health Education Series. Our topic tonight will focus on equine lameness, the clinical workup, and how specialized diagnostics can help in lameness localization diagnosis and help in guiding treatment plans to improve your horse's performance. You'll learn about the imaging capabilities the Piper Equine Hospital has to evaluate and diagnose causes of lameness in your horse, such as the lameness locator, standing MRI, standing CT, and new biological therapy that is available for treatment of joints or injured tendon and/or ligaments. We're grateful to have you all in attendance tonight, and on behalf of our team, I would like to welcome you to tonight's presentation. My name is Mindy Means. I'm a Senior Development Officer in the College of Veterinary Medicine. I work with our clinicians at the Leatherdale Equine Center and the West Metro Equine Practice, as well as Large Animal Hospital, in developing educational outreach webinars several times a year. The Leatherdale Equine Center includes the Piper Equine Hospital, Large Animal Hospital, and our West Metro Equine Ambulatory Practice, which is located in Long Lake, just west of Minneapolis. We are honored to serve many large animals along with their families each and every day while educating the next generation of large animal clinicians and practitioners. The VMC Animal Health Education Series features our leading experts covering a variety of topics in veterinary medicine that provide relevant health and medical information that will provide for a better life and well-being for animals and people. With questions we received prior to tonight's webinar and those that are asked this evening, we will do our best to cover the topics that have been asked most frequently during the Q&A at the end of this program. Please note that if your pre-submitted question or questions you may have asked tonight relates to your horse's specific medical care, it is best to contact either the Piper Equine Hospital or West Metro Equine Practice directly for consultation so your horse's care is personally assessed. Now I'd like to introduce you to our speaker for this evening, Dr. Jenna Young. Dr. Young is a board certified specialist in large animal surgery by the American College of Veterinary Surgeons. She works primarily at the University of Minnesota Piper Equine Hospital and Large Animal Hospital. Our specialty hospital is located on the St. Paul campus. Her areas of interest include lameness, orthopedic surgery, and colic surgery. We're grateful and very appreciative to have Dr. Young take the time tonight from the Piper Equine Hospital to join us this evening. And with that, I'd like to turn it over to Dr. Young.
Thank you, Mindy. All right, just a second while I share my screen. All right. So thank you all for joining us. And I know I've been fortunate to meet many of you and work with many of you and your horses already, and look forward to kind of meeting the rest of you at some point should your horse need us and need to come see us. So just a little brief background about me so you can get to know me a little better. I'm originally from Iowa, not far away. My family is still there, grew up on a farm, mostly crop farm. And then I went to Iowa State University for both my undergraduate and veterinary degrees. And then from there, I went south on I-35 to Oklahoma State in Stillwater, Oklahoma, and did a rotating equine internship, and then was fortunate enough to stay on there for an equine surgical residency as well. And then I came back north on 35, joined here at the University of Minnesota in July of 2019. And then I was lucky to have passed board certification in February last year, so a little over a year ago. All right, and a little bit, this is my mare, me and my mare, and she's 24 years old and retired now at this point, but she's one I grew up with since she was 2 years old, and she was mainly Western pleasure, but I've done a little of everything from hunter jumper stuff to barrels and poles, all those kinds of things. So I know a little bit about every area. So just an overview of kind of what I want to get through tonight and kind of the basics of the lameness exam we'll start with. And really, like, my goal of this presentation is not to make any of you lameness experts, but to help make you aware of, when to seek out a lameness exam for your horse and what to expect from us when you bring your horse in. And then go over some of the newer diagnostic modalities that we have to help with our lameness localizing, our imaging to help us get an accurate diagnosis, and then kind of briefly touch on some joint therapies that are available, and then specifically Prostrider, which is a newer biologic therapy that we recently have available. So kind of just bear with me for a little bit as we kind of break it back down to the basics. But as you all probably know, lameness refers to really any abnormality of a horse's gait or stance, and it could be caused by pain, a mechanical problem, or a neurological issue. It most commonly is due to musculoskeletal pain of some sort. So sometimes people will tell me that their horse is limping, but they don't seem to be in pain. Well, typically when they're limping, that is pain driven. Now, could it be a mechanical problem or a neurologic issue? Sure, but most commonly it is going to be due to musculoskeletal pain. And that can then range from anything from muscles, tendons, ligaments, bones, or joints. So when to really seek a lameness exam for your horse? So there are a lot of different symptoms basically that can mean that your horse is having pain, musculoskeletal pain. So it could be as simple as just a decrease in performance, and maybe your times are off recently, or things just don't seem quite normal like they should. Could be a subtle change in behavior or attitude, those kinds of things. Sometimes then when we get to a little more severe lameness, sometimes we'll notice them standing differently and maybe like pointing a foot out in front of them. And then it can range all the way to where we see an obvious head bob or toe touching on the hind limb, those kinds of things. And I do just want to stress the importance of it is really important to seek out and get a lameness exam on your horse as soon as it's recognized, because part of my job, what makes it challenging is when I see lamenesses that are a year or 2 or 3 down the road, and this has been a long standing problem, which then most often horses, if we have a hind limb lameness, they're going to offload their hind end and put more weight on their forelimbs. And now we're going to create secondary problems potentially on their forelimbs and vice versa. So sometimes when we have lamenesses going on for so much longer, we have compensatory issues that have developed as well. And then it makes it more challenging to really get to the root of the problem. And can really complicate our lameness exam and just make our job a little more difficult. But that is what we're here for, though, as well. So just want to stress that it's important as soon as you notice a lameness to try to get it evaluated as soon as possible. So then just a little bit, when to seek out a specialist. So every veterinarian out there, has a little bit of a different comfort level, and kind of depending on their comfort level, they may or may not refer you to a specialist themselves at some point when they don't feel comfortable. But also, subtle, intermittent, or multi-limb lamenesses that can be the very challenging ones. Oftentimes, also referring veterinarians might send us, they've worked up a lameness and localized it and been successful in doing that, but don't see anything on x-rays or on ultrasound. So then advanced imaging may be necessary. And that's where our CT or standing CT and standing MRI can come into play as well. And then if we have an unresolving lameness with treatment, so if we've been working at this for a while and we're still not getting anywhere, have that conversation with your veterinarian about, are there any other options, and, should we think about going to the university, those kinds of things. So kind of getting down to the basics of the lameness exam itself. And when you come here for a lameness exam, kind of what's going to be asked of you, and then what we're going to put your horse through to try to get to the bottom of things. So first off, we will start with asking you a quite detailed history. So we really want to know, and it's things to keep track of at home too, as far as when exactly did the lameness start? Has this been like kind of a little insidious onset? Has it been maybe he's been a little off, but now recently it's gotten worse? Just kind of keeping track of those things. And then, have you tried any NSAIDs, and has it responded? Has it improved with NSAID therapy? Just kind of all those different things. And we'll ask you, is it a really acute lameness? Did you ever notice any swelling on your horse's leg anywhere, or joint swelling, those kinds of things? Any heat anywhere? And so we'll kind of get a really, really good history from you that'll help kind of just is a piece of our puzzle then as we're going through our lameness exam and figuring this out. And so then we'll start with a basic physical exam on your horse, and then kind of proceed into more of our musculoskeletal exam, where we're really putting our hands kind of all over your horse, all over its joints, tendons, ligaments, everything, feeling for any swelling, heat, or pain when we're kind of squeeze over the tendons, those kinds of things. So we go through all of that, and then oftentimes we'll put on hoof testers as well, especially on the forelimbs, and we're just searching for any areas of heat, pain, or really any painful response to pressure on the feet when we're doing those hoof testers. And so then our active musculoskeletal exam, so that's now we head out to our arena and we'll usually walk and then jog your horse up and down hard surfaced area. And then we'll often take them out into the arena, into the sand, and put them on the lunge line as well and evaluate them there. So this, I'm just gonna show you guys a quick little video. Pedro left that sound, but so here I'm just showing you an example of a forelimb lameness. So if you guys can see, every time that left front foot hits the ground, the horse's head moves up ever so slightly. Play it kind of one more time here. So it is pretty subtle, but it is, you can tell the horse is moving a little differently. And I kind of get my head going with the horse as well to kind of figure out which leg it's lame on, and then you can kind of see as it goes away from us as well. I can kind of watch the tips of the ears to see. So this is an example of a primary forelimb lameness. We still might have a little something going on in the back end, but it's a primary forelimb lameness. And then the next one here is an example for you guys of a primary hindlimb lameness. So many of you can probably notice how quickly that this horse is getting off its left hind limb, but you'll actually even see this horse has a head bob on the forelimb side as well. So we see a head bob with this, but it is because it's such a severe hind limb lameness that the horse is compensating and carrying its weight, trying to get off that left hind leg, that it actually kind of makes it look like a left forelimb lameness. And some of you may know, and have said this at certain times, but if we have a lameness that's on an ipsilateral side, so if we have a left front and a left hind lameness, oftentimes, if the severity correlates, it oftentimes is a primary hind limb lameness. And then if we have a contralateral limb lameness, like a right front and a left hind, then oftentimes the right front would be the primary lameness. It's just kind of how the horse compensates during their trot. And so then another part to our active musculoskeletal exam, after we've kind of done all of these things and taken them out on the lunge line oftentimes as well, is then we proceed with flexion tests. So flexion tests may be helpful if the lameness is subtle and there's no obvious signs of a problem. So that basically we're just like you or I, we bend down on our knees and hold that position for a while, and then we stand up and we try to walk off. Some of us that have some knee issues, those kinds of things, may be a little more sore when we walk or jog off. And so that's the same idea of what we're doing with this in horses. So we're trying to stress a certain joint and then asking them to jog off, and we're comparing it to our baseline exam. And is it worse or the same as baseline? Sometimes when I'll flex one leg, it'll actually make them worse on the other side leg. Because then they had to bear all the weight on that other side, depending kind of on what their issue is. But this is just, one test that we further use as a piece of our puzzle. Again, it's not super specific, especially kind of in the hind limb, because of the horse's what's called the reciprocal apparatus. As many of you probably have noticed, when you flex one joint in the hind limb, they all flex. So it's hard to really isolate a specific joint to flex, but we do our best to try to isolate the distal limb versus the kind of full limb and hock area, and then the stifle as well with some of our flexion tests. So that is part of our lameness exam as well. So a little bit then on the grading scale. So our lameness grading scale is put out by the American Association of Equine Practitioners. It's kind of the main scale that most of us equine practitioners use, so that when we talk to each other about a lameness, I can talk to your vet and they can say, oh, this horse, I've got a horse that's grade 3 out of 5 lame, or a 1 out of 5 that's pretty challenging because it's so subtle. All the way to a 5 being a horse that is minimally weight bearing and or potentially hopping on the limb. So we break it down a little bit. Basically, a 0 is a sound horse. A 1 is lameness that's difficult to observe, and it's not consistently apparent even when we put them through certain tests. So when we put them through tight circles and on hard ground, those kinds of things, it's still inconsistent. A 2 is when it's difficult to observe, usually like trotting in a straight line, or it's inconsistent. I would say trotting in a straight line, but then it's pretty consistent when we put them on a turn. And that could be on the inside leg or the outside leg of the circle, depending. And then a grade 3 is where it's pretty consistently observable at a trot under all circumstances. And as you might imagine, like we saw in that video, the forelimb lame horse, we can have a horse like that where we're only seeing a little bit, probably centimeters to a couple inches of head movement, all the way to a horse that's got a severe head bob with every step at the jog. Then a grade 4 is when the lameness actually becomes evident at a walk. And then, as I said before, a 5 is where they pretty much won't put any weight on the leg or just barely toe touch. And so this is part of our lameness exam. We'll grade your horse. First, we'll say, is it lame or is it sound? Okay, well, great. If it's sound, that's a very good thing, hopefully for you and your horse. But if it is lame, then we'll usually give it a grade, and obviously the leg that it's lame on. So now I was just going to go into talking a little bit about the lameness locator and what it is, and how can this newer technology assist us in our lameness evaluations. So for those of you that don't know much about it, so it's basically the sensor system that we put on your horse, and then they're Bluetooth sensors that talk to a computer, and then the computer, the sensors do the measurements, send them to the computer, and the computer does some calculations and things and gives us a report, which I'll show you here in a bit. But this is really an adjunctive to our subjective lameness evaluation. So we're always doing a subjective lameness evaluation. Rarely, though, I will say, when I put a lameness locator on the horse, do I disagree with it? But that's why we're always looking at your horse as well with our eyes. But it's trying to just make lameness a more objective evaluation and giving us a little bit better idea when to use it. Is really, I use it a lot on subtle lamenesses or multi-limb lamenesses. If your horse is grade 4 out of 5 lame, I'm not going to put this on your horse because most of the time I'm not going to be jogging your horse very long if they're that sore, or doing much jogging at all if they're lame at the walk. So those subtle or multi-limb lamenesses, I find it I find it good to put it on those just because it can detect we're talking less than millimeter of movement that this thing is detecting. So more than what our human eye can see. So the other times that I really like to use this is when potentially I'm going to be doing diagnostic analgesia or nerve or joint blocks, if you have heard of those, and we'll get into that a little bit here in a bit. But it helps us interpret our response to that diagnostic analgesia, because if I have a forelimb lameness, it measures that forelimb movement with every stride. It measures that head movement up and down. And then after I block the horse and trying to localize, then the idea is if I do a nerve block and your horse goes sound, then the problem is coming from somewhere below that area. And so when the horse jogs off again, now the system measures our head movement as much less and gives us actually a % improvement on the lameness locator as well. And then the other thing I find it helpful for is interpreting our progress on recheck evaluations. So some of soft tissue injuries, those kinds of things where we have prescribed a period of rest for your horse and a rehab program, we then can use this system. We can put it on, a month or 2 months down the road or a year later and see what has changed and have we made progress in that aspect. And I find it, we can obviously take videos of your horse as well, but the measurements are nice to have as well. And I think it just provides a little bit more piece to the puzzle as well. Not to say we don't put it on every horse again, but it is something that we do have here more recently that we're using on more and more cases. So essentially what it's doing, so it's 3 different sensors that are going to go on your horse. So one goes on the head, this little hat that goes over the ears and tucks under your halter, and then there's a little sensor between the ears there. Another one goes on the pelvis, so at the highest point of the pelvis, and then right on midline as well. And then the last one goes around the right front pastern, and so it always goes on that right front pastern, because the system knows then when that right front foot is on the ground, then it's measuring that head movement when it's occurring in relation to that right front foot. And it knows where every other foot is on the horse because it's always on that right front foot, if that makes sense. So it is measuring then movement of the head, and then also it's calculating or measuring to the pelvic movement, and it's really looking for asymmetric weight bearing on the limbs. And this is with a precision really that the human eye can't necessarily match in those really subtle lamenesses that we need precise measurement. So the one thing I will say with that, so it's looking at, especially on the pelvis, it's looking for asymmetries between pelvic movement. So one of the things when I'm watching a pelvic limb or a hind limb lameness is I'm looking at the pelvis of that horse. So each horse this makes sense. You're going to have some movement, right? But the side that the horse is trying to get off of is going to be moving a lot more than the other side. And so that is what this lameness locator, the sensors, is measuring too. So if there's a hike or a drop on one side, it's going to pick that up. Now, the one caveat of the system, it's measuring that asymmetry. And so if we have, say, a bilateral hind limb lameness, sometimes this system won't necessarily pick that up. And then again, that's why we're doing our subjective evaluation ourselves as well. And so it does further, and you'll see this on the reports coming up, but the stride cycle timing, it times it via the pastern sensor there on the right front pastern. And so it determines when in the stride also that the lameness is occurring, besides which foot, it determines which foot it's lame on. And then it further classifies it into, is it happening? So the head movement, is it happening right as that horse's foot is hitting the ground? So they just don't want to land as hard on it and their head goes up and they're trying to take the weight off of that? Or does it happen when the horse is more, the weight is more underneath them, if that makes sense, in the mid stance position? Or does it happen more when, right about when that foot is about to push off? And so that also tells us a little bit more, another piece to the puzzle. So a lot of times an impact lameness will tend to be bone or joint issues, because that concussive force when the horse, that foot hits the ground, that's what's painful to them. Versus a push-off lameness a lot of times can be a soft tissue type injury, because that's when the stretch on those tendons is occurring, is when that leg is out behind them and they're going to push off, and they're using the muscles and tendons to do that. And so that is one thing that this system does as well to help kind of clue us in as well. So this is just a little schematic kind of where we're placing those sensors again on the head and the pelvis, and then on the right forelimb. And then it is Bluetooth to our computer system. And this is kind of a schematic then of the report that we'll see. And I have a few more coming up here I'll show you, but this is one on a horse here that we've got. So we've got the little hat. Some horses are a little like, what are you putting on me, when I go to try to put this on them? But most of them tolerate it just fine. And then this wraps, we have to wrap it a little bit tight, but it just doesn't affect the horse, and the pelvic sensor as well. So this is what a report looks like with our lameness locator. So when I'll kind of blow it up, but essentially at the top, it gives us some information as far as, we're doing a straight line. What is the surface we're on? Is a hard surface, soft surface? So this was concrete. Have we done any blocks on this horse? Those kinds of things. So I'll kind of blow it up. So this box here is our forelimb strides. And so this is an example then of a horse. So each one of these blue lines is every single time the left front limb hit the ground and the horse's head went up. And then this red line is the sum of basically all of these blue lines. And then one other thing to note is this gray circle is basically within normal limits. So if this red line was within that gray circle, this horse would be then called sound if these weren't so long, kind of thing. But so then this is where we have a left forelimb lameness, we have impact, mid stance, and push off. So this is definitely towards the mid stance side of lameness. So that means that the head movement is mostly occurring kind of right after that horse's foot is hitting the ground and as that weight is underneath them. And then this is showing you the hind limb. So we've got a little bit on this hind limb, but mostly, again, everything's pretty symmetric on this horse. And the gray line is again within normal limits. So we do have a little bit of variation that can be within normal. And then in the hind limbs, it does characterize it into push off and impact lameness as well. And then at the very bottom of this report, it gives us this trial aid, which does tell us there's strong evidence of mild to moderate left front mid stance lameness. It tells us there's no evidence of lameness on any other leg. And this strong evidence just means that it's pretty consistent. So when we say like a grade 1 out of 5 lameness, those ones that are inconsistent, that's when it'll usually say there is mild evidence of a mild to moderate left front mid stance lameness. So those are the even more subtle ones, but this one is pretty consistent. So it's strong evidence of a mild to moderate left front mid stance lameness. So this is just kind of an example of the report that we get. This is another one that's kind of showing, this is actually a primary hind limb lameness. So what I sorry, this is the lunge line. So this is that same horse now on the lunge line. And you can see that then both directions, we still have a left forelimb lameness, but the timing changed just a little bit towards a push off when we're actually going to the right. So yeah, this one's the lunge left on the left side and the lunge to the right on the right side. And then we have a little bit of stuff in the hind end that seems to be on the, when we're going to the right. Again, down here, it'll tell us there's evidence of a left front push-off lameness, lunging both directions. It does say there's evidence of a right hind lameness, but then it will tell us this pattern could be seen sometimes in normal horses. So we take it with a grain of salt kind of thing, or we repeat it to see if it is real. This is then a hind limb lameness that I'm showing you. So we have, you can see all the red and green lines. So that's the same thing. That's that pelvic movement that's occurring more so on that left side, showing up as a left hind limb lameness. And then we also have a little bit of a left forelimb lameness to go along with this. I didn't blow the bottom up here, but so there is basically what our trial aid down below says, there is some strong evidence of mild to moderate left front mid stance lameness. But we have moderate evidence of mild to moderate left hind impact, strong evidence of a moderate left hind push off. So we have a pretty severe left hind limb lameness component. And so this is where it actually tells us these results may be indicative of primary left hind lameness, because as I kind of said before, if we have a same side lameness and the severity fits, so if the severity of that hind limb is pretty severe, it can cause what looks like a left forelimb lameness. And that's what this is showing us here. So the lameness locator takes kind of all these things into account as well, which is pretty cool. So kind of where do we go next? So after our lameness, so we've identified if your horse is lame or sound, we've identified what limb it's lame on, or limbs, sometimes multiple limbs. So kind of where we go next does depend on a lot of things. So sometimes we will choose to, if the lameness is severe enough, meaning probably just not a grade 1 lameness where it's pretty inconsistent. So if it's a grade 2 or a grade 3, a lot of times we will proceed to localize that lameness with either nerve or joint blocks, which we'll talk about a little bit here in a bit. Or sometimes we'll proceed with imaging, especially if your horse is kind of a pretty inconsistent grade 1, can be very challenging to truly say, if I can't measure it with the lameness locator and it is really subtle that I'm seeing with my eye, it's really going to be hard to know, is it improved with a block of some sort? So some of those will go to imaging. Other things it can depend on, if your horse flexes severely positive to a certain area, a lot of times we will jump then to start imaging and looking at that area to see what's going on as well. Other things too, if it's a multi-limb lameness and it's not real clear which one is the primary lameness, we might be talking about doing some other things as well. And the other thing too is your horse's cooperation. So every horse has a little bit of a limit as far as how many needle pokes go into their leg on any given day or at all. So that is one thing that is taken into consideration too when we're trying to decide, do we try to localize this lameness or do we kind of do some imaging? But the one thing I'll tell you is we do imaging, and sometimes we see things that could just be incidental findings. We could see a bit of arthritis, those kinds of things. And it may not truly be the source of your horse's lameness because a horse doesn't walk on their x-rays kind of thing. So we do try as best we can to truly localize that lameness and then proceed with imaging of that area. So diagnostic analges, I've mentioned this already a couple times. So nerve or joint blocks, these are where we basically kind of methodically numb certain areas. So with nerve blocks, we're numbing a nerve so this is a picture of a Palmar digital nerve block, which is basically a heel block. It blocks kind of the caudal 2/3 of the foot, or the back half of the foot, if that makes sense, back 2/3 of the foot. And so what we're doing is we're putting a bit of numbing agent or local anesthetic, just like your eye that goes to the dentist and gets a numbing agent. So we're numbing those nerves so that then the heel region of the horse is numbed. And then we go back out, we jog your horse, and we can determine whether or not they're improved at all, or if they're the same, or sometimes we make them a little bit worse before we make them better. And so this then with nerve blocks, we proceed in a stepwise fashion and kind of work our way up the leg, because it will numb from that point down. that makes sense. Joint blocks are a little different in that we can jump around a little bit more because that local anesthetic is contained within a joint. So if we have a high suspicion maybe of a stifle joint lameness, sometimes I will jump just to the stifle, block that stifle, and see if there's improvement or not. If there's not improvement, then we can even go back down and do nerve blocks, those kinds of things. Nerve blocks are a little bit safer than our joint blocks. Again, with joint blocks, we're having to go into the joint, and there's always a little bit of risk of infection, but that risk is very low, and we are scrubbing to get that area really good and clean before we do that joint block. And it is, very useful, just because in a nerve block, when we're doing this palmar digital nerve block, it's not blocking a specific structure. I mean, we have the navicular bone, we have the deep digital flexor tendon, we have collateral subsensory ligaments, those kinds of things all in that location that we are blocking. And so when we're blocking a joint, it's a little bit more focused just to that joint. Now we do still have some things surrounding that joint, but it is a little more focals. So then this is kind of showing a report of the lameness locator on a horse that we've done the nerve block on. So this is that same horse that I was showing you previously that had the left forelimb lameness, not much in the hind. And now this side on the right is after we've done that palmar digital nerve block, or the heel area on that left forelimb. And so now you guys can see the difference. So the timing of the lameness has changed a little bit. So now we're towards the push off side of lameness. And then you can see the length of these blue lines. So we were somewhere around 20 to 30 millimeters, so 2 to 3 centimeters of movement previously, and now we're down to, well, probably 10 to 15 millimeters of movement, 1 to 1.5 centimeters. So, and then when we watch this horse go, he looked significantly better as well to our eye as he did to the lameness locator. And so then at the bottom here, I've put in that we did this block. And then when I compare the block, it tells me here that this blocking eliminated the left forelimb lameness. So we successfully localized where this horse's lameness was coming from. And sometimes it won't be, this one improved enough that it's saying 100% it eliminated that lameness. Whereas oftentimes we aren't going to see that. Usually with nerve blocks, we like to see, around at least a 75-80% improvement in lameness to say that, that is for sure the region that it's coming from. Sometimes when it's only a 40-50% improvement, maybe we have multiple issues going on. So it varies a little bit, but this will give you, based on the measurements that it's taking there and the calculations it's doing, it'll give me a percent improvement as well, say 40% or 50% improvement in this lameness. All right, so getting a little bit into imaging our options. So we've localized the lameness. Now we need to proceed with some sort of imaging to actually get a diagnosis of what is going on. So I just kind of broke it down real generally into kind of bone and soft tissue and what's used more for one versus the other. So we'll go into each a little more in depth, but in general, radiographs and CT are going to be best for looking at bone and joints. And then ultrasound and MRI is going to be most useful for looking at our soft tissues and our tendons, ligaments, those kinds of things. There is definitely some overlap between those. And we'll talk about that a little more in depth. And then kind of at the bottom in its own category is bone scan or nuclear scintigraphy. If some of you have heard that term before, that is actually, instead of just being an imaging modality, we still put it in our imaging category, but it helps us localize a lameness as well. And we'll talk a little more in depth about it here when we get there. So start with x-rays or radiographs. So this is really our first line imaging test that we often still go to, even though we do have all these fancy diagnostic modalities too, like the MRI and CT, but radiographs are still very, very helpful. They are good for bone. They're less useful for soft tissue. So we can't see the specifics or the inside of the tendons, ligaments, those kinds of things. Excuse me, we can get an idea of soft tissue swelling on the leg or maybe joint effusion or extra fluid within a joint. We can kind of get an idea of on x-rays, but mostly we are looking at bone and the edges of the joints, those kinds of things. And then x-rays are giving us a two-dimensional image. So the CT versus the CT will give us a three-dimensional image, which you'll see here in a bit. And radiographs still pretty inexpensive. So it's oftentimes a place where we will start with your horse. And here's just some examples of things that can be diagnosed kind of every day on radiograph. So we have a little fetlock chip fracture here on this first one. Then I have an example here of some lower hock arthritis. So our tarsal metatarsal and our distal tarsal joints here, you can see kind of these hooks or osteophytes, bone spurs, we call them, at the edges of the joint there. And then this is an image of a horse with a stifle cyst or lesion there that we can find on the x-rays. So then on to ultrasound. So ultrasound is very good for soft tissues, and so tendons, ligaments, joint capsules, looking at different fluids. And then we can see the bone surface, but we can't see anything deep to that, especially of healthy bone. So of healthy bone, it hits the bone surface and it bounces back to us and doesn't image anything deep to that. So one other thing that ultrasound is really useful for is that it is really the only one that provides us a real-time evaluation of the soft tissues. So it utilizes sound waves that travel through the tissues and then produce an image when it comes back to the machine. And it's so kind of then the real-time evaluation of it that I'm meaning is I can, have the limb on the ground in weight bearing, and then I can also pick up that limb and flex it and unload those tendons to see if it changes what the tendon looks like. So there are certain tears of tendons that the tendon fibers can be compressed together when the horse is weight bearing. And then when we unload that limb, then they open up and we can actually diagnose and see a tear. So that's why this modality is still very, very useful for us. The limitations of it, again, it can't see the inside of healthy bone, but then it also can't image really within the hoof. And as many of you probably know, about 90% of forelimb lameness is in that hoof. So we need something that can look inside that hoof. And there are so many little tendons, ligaments within that hoof that are difficult to image with anything really but an MRI. So ultrasound, again, is fairly inexpensive, as well as one of our diagnostic modalities here. So this is an ultrasound image I'm showing you. So we're kind of in the upper to mid cannon bone region of a horse here. So we have our superficial digital flexor tendon, we have our deep digital flexor tendon, we have our check ligament here, and then we have our suspensory ligament here, and then our back of our cannon bone is this bright white line there. Many of you can probably see that there is this black hole within the suspensory ligament. So this is an example of a tear within the suspensory ligament on a horse. All right, so on to CT, or computed tomography. So this really is kind of our gold standard, best modality for evaluating bone. Recently, we do a better job imaging soft tissue with this as well. We have some different filters that we can apply to our images that actually are doing a better job nowadays of allowing us to even diagnose some tendon or ligament lesions on the CT as well. So this is creating a cross-sectional three-dimensional image for us. So we get multiple different planes to look at your horse's legs and the bones and joints. And then with this modality, we can image from the hock, usually just above the hock or just above the carpus, and then down. Sometimes we have to get a little fancy, which I'll show you in some pictures coming up. Usually the limitation is the horse's abdomen. We can only raise this CT so far up before it hits their abdomen. And so that sometimes we'll put these forelimbs up on blocks to kind of raise that abdomen up a little bit to help us get a little bit higher. Then this is a very quick procedure. Usually, by the time we bring your horse out of the stall and put it back in the stall, it's usually 10 to 20 minutes. Sometimes we'll have to do a second scan just because there was a little bit of motion. Maybe your horse was swaying, so they do have to be sedated for this, because some of them don't like the noise, or if they by chance moved and hit the edge of the CT, it might scare them. So we do sedate them for this, but it's a relatively quick procedure, and we're spending about double what we would on a series of x-rays, but we also get a larger area. So instead of just taking both hocks, we're getting the fetlocks, we're getting the foot, all those kinds of things as well with this scan. Oh, here's just a little this little video that you guys can see. Many you might have seen this before, but so you can kind of see in that video too how the CT moves up around your horse's legs, and then so we bring it up, and then we start the scan, and it scans on its way back down. So if there's any issues, if your horse is leaning, swaying during our process of bringing it up, we can always abort mission and bring it back down and get the horse situated better before we start it again. So here's an example. You can kind of see of the horse up on blocks to kind of raise its forelimbs up and its abdomen so that we can get just a little bit higher. And here's some images just to show you guys of what we get on a CT. So we get kind of multiple planes of images, but this is a cross-sectional image, and then this is kind of a side-to-side sagittal view, like what we get with x-rays and things, but we don't get this cross-sectional image with x-rays. This horse you guys can probably all see. So in the coffin bone, there is this large mass that has expanded, and a lot of this coffin bone is now gone and even expanded into the coffin joint here as well. A pretty severe case. And then this is another kind of video here just showing you, this is the coffin bone, and then this is actually the navicular bone back here. And this is a horse that has some pretty severe increase in the size of these synovial invaginations within the navicular bone, which is telling us there's a lot of inflammation within that navicular bone. And this horse has what I would term pretty decent navicular syndrome, or moderate navicular syndrome, moderate to severe, depending on the lameness of this horse as well. This is just another example of something that I can see best on the CT. You can get a little idea of it on x-rays, but best really on the CT to get an idea of where these are actually located. So these are kind of similar to cystic-like structures. This is a condition called axial osteitis of the proximal sesamoid bones. We think it's due to trauma. There's a ligament that goes between the sesamoid bones here, and we think it's trauma to that ligament then causes these cystic-like structures to form. And so this CT really helped for the surgical planning in this case, to allow us the best access through surgery to get to these areas and debride these lesions and try to stimulate remodeling. Here's an example of an actual three-dimensional bone structure that we can see as well with the CT. It does this 3D reconstruction. This is an example of actually a fracture of the short pastern bone, or our P2 bone that we're seeing there. And so CT is really beneficial for all these bone things, especially like fractures, surgical planning, those kinds of things. It's really invaluable to us as surgeons and as veterinarians. All right, so getting into a little bit on standing MRI. So this is our gold standard diagnostic modality for soft tissue injuries. So tendons, ligaments, joint capsules, those kinds of things. It does also evaluate bone fairly well, and it's one of the only things that can really look at fluid within the bone and get an idea of bone inflammation. Again, our standing MRI can evaluate up to the carpus and hock. Usually, depending on the size of the horse, we may or may not be able to get the actual carpus or hock, especially a larger horse. A lot of times we have to put a coil around their leg. And then in the next picture, I'll show you, they kind of go into this machine, but the coil has to fit around the size. And as you go up the leg gets larger. And so larger horses, it doesn't always work. This is a pretty lengthy procedure that's done under standing sedation. And it is a quite expensive procedure compared to the others. So we want to for sure have localized your horse's lameness before we go into this, because we can't just do the whole leg kind of thing. Your horse would be have gotten lots of sedation in order to do that. So we like to localize it to a couple different regions and scan those regions. So here's kind of a picture of our MRI here. And so the horse, that leg, they're scanning the right front leg, is positioned within the MRI, and we do multiple sequences of the MRI, and here's a person putting the coil on the leg. Here's an example of the images that we get, and you can see kind of, I think they're really pretty images of a horse's foot here. This is the sagittal or the side to side. Again, here's the cross-sectional image. And this horse, if you can see this white line, so the black here is normal deep digital flexor tendon that comes all the way down around the navicular bone and attaches on the back of the coffin bone. But the bright white in the middle of this is a tear within that deep digital flexor tendon. And then we can also see the tear right here on this cross-sectional image as well. So these are the things that the MRI really picks up, is these tendon lesions, especially things down within the foot where we can't image very well with the ultrasound. That's where our MRI really comes into play. Nuclear scintigraphy, just going to touch on this really quick. I know I'm getting a little bit long on time, but this is bone scan. We use it to localize orthopedic conditions. A lot of times things, lamenesses that we can't block out, or we suspect something in the neck or the back or the pelvis, something higher up that are difficult to image anyway. So basically we do give your horse a radioactive isotope IV, and then it travels to areas of bone that are undergoing rapid bony turnover, which is aka the site of the injury. So anywhere that has an injury, the horse is going to be turning over that bone, resorbing it, laying down new bone. And so the radioactive isotope goes to those areas, and then they light up as hot spots on this scan. It is an expensive procedure again as well. But here's some images that we get from it. Here's an example of a fetlock. So you can kind of get the outline of the horse's foot down here, pastern region, then fetlock here, and that's a hot spot lit up on this horse. On the inside of the lower hock joints, we have a hot spot. This is a cervical spine of the horse, or the neck, and then this is one of the cervical set joints that has lit up on this horse. And so after bone scan, we still need to follow it up with some sort of imaging. Might be x-rays, might be a CT, depending on where it's located. If it's a neck, we're usually doing x-rays, or if it's high up on the neck, maybe the CT. If it's limbs that are hock or carpus below, oftentimes we'll recommend the CT, just because it does give us a little bit better image or quite a bit better image than our x-rays, just because it is that three-dimensional view. So quickly getting into the treatment therapies. So this is just depending on the exact cause of your horse's lameness, the location, an area that's affected, that's really going to guide our treatment recommendation. This is not an all-inclusive list by any means. This is just kind of in general, what are options out there for our horses. So for example, a horse with osteoarthritis, a lot of times our go-to treatment for that joint is a steroid and HA. Some of the other biologics we have out there are IRAP, if some of you are familiar with that. And then Prostrider is one of our newer one that I'm going to go a little more in depth on, which Prostrider actually combines IRAP and PRP, or platelet-rich plasma, which you'll see is kind of on the tendon and ligament side. Again, on the joint stuff, though, a lot of times this could be combined with a rest and rehab program. It could be a brief rest period and then back to work and see how your horse does. Oftentimes we're prescribing shoeing recommendations. Shockwave could be an adjunctive therapy as well, supplements such as like Adequan or Legend, and then also potentially NSAID therapy as well. And then when we get on the tendon and ligament side, still really the best of the best that we can do for some of these tendons and ligaments is just pure rest and then a rehab program. The few I have on the list are the Prostrider, the platelet-rich plasma, or PRP, and stem cells on here. There still is not a ton of great research out to back these up and say that they are better than just pure rest of this horse alone and allowing the body to heal itself. There are certain instances where I might reach for one of these, but it's really going to be case dependent on your horse. And a lot of times same thing, shoeing recommendations, potentially shockwave to help with stimulating healing of an area. Therapeutic ultrasound is another thing our West Metro team has available to help stimulate healing as well. And then again, NSAID therapy in these as well. So just going to focus a little bit more on Prostrider here, but before I get too much, I'm just going to say kind of most importantly, it is really valuable to have an actual diagnosis. And that's why we're going through, localizing lameness to imaging to try to figure out, what is exactly going on. So with an actual diagnosis, treatment is useful, and it's not just a waste of time and money. So if we don't know the area and we're just kind of taking a shot in the dark, then it may be just a waste of time and money. So getting an accurate diagnosis to know what we're treating is going to be the best. So what is Prostride? It is an autologous, meaning from your own horse's blood, platelet solution. So we take a blood sample from your horse and then we do some different things to it, but basically it provides anti-inflammatory mediators of IRAP, which, kind of long story short, it's just an anti-inflammatory that we are processing from your horse's own blood. And then we have beneficial growth factors from platelet-rich plasma that is, again, within your own horse's blood, that we are harvesting those factors and putting them into this product and then injecting them into a joint or into a tendon ligament to provide growth factors to stimulate healing and then potential anti-inflammatory effects as well. So useful for osteoarthritis. I do put in parentheses there high motion joints. I do think our steroids, really for our low motion joints like our hocks and things, our steroids are really still kind of our best treatment option. Not to say we couldn't try Prostride, but the Prostride doesn't seem to be, in my experience, quite as potent as our typical steroids and HA. Again, soft tissue injuries potentially as well, and less commonly for wounds. So this is just a little schematic of what we do. We draw blood, we put it into the one container basically, and then put it in a centrifuge, spin it, and then we pull it out, put it in this next one. Then this one kind of creates the IRAP component of our Prostride. And then we pull it out of this container and now it's ready to be injected into the joint. Again, of course, all done very sterilely. Very important for this going into a joint. So I just pulled a couple of the literature out there, the papers on this, to kind of show you guys. This is probably the best paper there is out there on Prostride, and it did a pretty good job of looking at horses that had arthritis. They got a single dose of Prostride, and the horses that got the Prostride, they did have a control that just got saline as well, so that they could actually have a comparison control to compare to. So they did see a significant improvement in the subjective lameness score. They also did a more objective component as well, using a force plate. So it measures the force that a horse is putting on that limb. Obviously, if they're putting less weight, that's less force on that limb. So they measured that as well and saw significant improvement in weight-bearing symmetry between the two sides. And they also saw improved range of motion without signs of pain. This is probably kind of the best paper that gives us a little bit of good evidence that Prostride is a good thing for osteoarthritis in horses. Now, again, there's not a paper out there that I know of that compares Prostride to the corticosteroids to see if one is, better than the other kind of thing. But the main reason kind of to reach for this is some of those higher motion joints. There are some studies out there that speculate that long-term high dose steroid use may be detrimental to cartilage. Most of those studies are at doses much higher than what we are using in your horses and at much shorter frequencies. So a couple of those studies, they were injecting horses with the steroids at 2-week intervals, which is not something we would ever recommend in a clinical case. So in that aspect, steroids, we use them all the time. They don't necessarily, in my hands, seem to have a lot of detrimental effects to cartilage, but maybe over a really prolonged time. So this is just kind of the more natural solution that we can do, where we harvest it from your own horse's blood and put it through this process to get those good growth factors and the anti-inflammatory effects, and then put it back into the joint as well. This is one study that is out there on looking at its treatment, the use of Prostride for tendon injuries. They evaluated, it was a little more in-depth paper that they kind of looked at actual gene expression and things on a cellular level, as well as looking at ultrasound. And they did not see a difference with the ultrasound. There was some changes on the gene expression. I believe that they speculated there might have been some improvements in healing characteristics, but again, nothing was really statistically significantly different, which to us is kind of, it might help, it might not. So wrapping things up, I know we're close to time, but it is important that, as I said in the beginning, important to have a lameness evaluated as soon as it's recognized. Our lameness locator may be useful for helping to localize those subtle or multi-limb lamenesses, also helpful for blocking or treatment of a soft tissue injury when we're doing recheck exams to see, are we actually making progress? And then CT really allows us for a much better evaluation of bone and joints than our standard x-rays. May also, recently we've been diagnosing some soft tissue lesions on the CT as well. Again, MRI is our go-to for those soft tissue injuries, but CT is quite inexpensive compared to that MRI. So oftentimes we'll start with that. And then a Prostrider, it is a promising treatment, especially for osteoarthritis of the joints, and then potentially in certain cases of tendon and ligament injuries as well. All right, now we've gotten to the point of questions.
Thank you, Jenna. That was awesome. We have some questions. We have actually 6 questions. I'm going to hold on here a sec. We have 5 pre-submitted and then 1 that came in this evening. So the first one is, what is the difference between a navicular cyst and navicular?
Yeah, so essentially a navicular cyst, like I kind of showed in that one CT where those synovial invaginations were within that navicular bone. A navicular cyst is really when some of those synovial invaginations that are enlarged start kind of coalescing into one large one, and we actually get a cystic structure forming within the bone due to inflammation and things. Navicular, just in general, I usually call it navicular syndrome. I mean, that can basically, a navicular cyst can be a part of navicular syndrome, because navicular syndrome in and of itself is a whole very complex of issues. We have the navicular bone that's involved. We have the bursa surrounding the bone that could be involved. We have the deep digital flexor tendon that runs there that can also be affected. We have little, what we call suspensory ligaments on the sides of the navicular bone. There's many, many little structures that can be involved in navicular syndrome. And so it's not necessarily as straightforward as my horse has navicular. There's many things that can go into it. And that's where, the MRI is probably our best modality. Again, we can get an idea on the CT, but the MRI for those small soft tissues, the tendons, ligaments down within the hoof, that we can better characterize navicular.
Perfect.
That answers that.
What is the newest treatment for hawk arthritis?
Good one. So I kind of said this in the presentation, but for our typical distal hawk arthritis, so those 2 lower joints of our hocks and horses that are getting hawk injections, there's really not any new great magical therapy out there. Our typical corticosteroid and HA injections really, for most horses, seem to do the job and get the job done well. Now, there's certain instances where we may choose maybe to do Prostrider in those cases, or there's certain instances where actually surgery to help those joints fuse may be an option, but that is very kind of case dependent as well. But that's just one other thing that's out there. But again, probably mainly our steroid injections with HA is still kind of our go-to for hawk arthritis.
Are there any topicals that are good for arthritis in a joint?
Topical therapy, yeah. So there is one product that's out there. If you're familiar with it, it's Surpass, that is formulated for horses and labeled for use for osteoarthritis in horses. I don't use it a ton, but it could be an adjunctive to our other therapies as well. It is an NSAID. So we do have to be careful about the amount that we're putting on the horse and the frequency at which we're putting it on the horse. It is absorbed systemically. But it is another option potentially out there. The limitations to it is I like to clip that hair to make sure it's actually getting absorbed. So it's not necessarily a great long-term solution, but if we have just an acutely inflamed joint for a certain reason, it might be something in a short-term period that would be an option for a horse. But things that you can just buy, DMSO, those kinds of things that are anti-inflammatory, none of that is really getting absorbed all the way to the joint to really have an effect on the joint.
Okay. Are there any effective biologic treatments for torn ligaments?
Yeah, so this is where the Prostride or the platelet-rich plasma component comes into play. Stem cells, there's a lot of things out there on stem cells as well, but I think we still don't know the full extent of stem cells. Again, Prostride or the platelet-rich plasma component of the Prostride may be beneficial in certain cases. It may not be something that I jump to right off the bat. I definitely, the rest and whole rehab program is really kind of still the best option for the horse. Just because there's not enough evidence. I know there are quite a few people out there that do use it, quite a few veterinarians out there that do use it and do feel that it helps. But again, there's not a ton of peer-reviewed literature out there that we as veterinarians like to see before we really start using a product. We might not know then the full extent of actually the downsides to it as well before it's fully evaluated with the research. So
are there any advancements in treatment for arthritic joints, particularly in the coffin and pastern area? And then she goes on, or he or she goes on to say, right now my horse gets OSPOS and joint injections. It's working so far, but I'm looking ahead in order to keep him comfortable and moving.
Yeah, so just again, treatment for arthritic joints, steroids again and HA are kind of our go-to at first. In those cases, the coffin joint would be a high motion joint that I would consider. If the horse has responded well to steroid therapy in that coffin joint, that would be one where I would then potentially want to try Prostride on. Now, the Prostride is probably about double the cost of our typical steroid injections. So that can be a prohibiting factor in some cases for some people. But if we already know that there is a response there, the Prostride may be a little more friendly to the cartilage and may just help prolong the joint health for a longer period of time.
I know we're a little bit over time, but we've got 3 questions if you don't mind hanging in there, and we'll just we'll go through. Kind of going back to the hawks. So can you share your experience, thoughts on newer injectable Notrex synthetic lubricant, and how does this therapy compare to corticosteroid injections, specifically any role for stifle arthritis? Well, there's, there's like 3 questions here.
So, yeah, there are multiple. Let me answer that
there's
first.
So I'll stop there, and then because there's a follow-up question.
Yeah, so Noltrex, I personally have not used it a ton. I have used it a little bit, and then have talked to many other veterinarians that have used it quite a bit. The one thing, so Noltrex, for those of you that don't know, it's basically another joint synthetic lubricant kind of thing out there that's thought to be an anti-inflammatory as well. And the one thing about it is the actual component is polyacrylamide gel that is quite large molecules. And I have not had any, but I've personally heard of multiple horses getting joint flares from this therapy. So it does scare me a little bit to use, and especially if a horse were to get a septic joint with this therapy, those molecules are very large and in a gel-like formulation that I worry. So treatment for a septic joint is then to put needles or our arthroscope in and flush things out. And my concern is that Noltrex may not be able to get it fully out of the joint if this horse were to develop a complication such as a flare or a septic joint. So at this time, I'm really not prescribing it or using it. There, again, isn't really any peer-reviewed literature out there to back up its use. And really, I'm not one to before I see that real evidence out there, I'm not one to really change what has been working for us pretty well so far.
Okay. And then we'll just do one more question here.
Okay.
Are you familiar with, I believe it's Spring with osteocushion technology? When injected into an affected joint, it creates a shock absorbing matrix that works with synovial fluid to mimic the protective form and function of natural healthy joint cartilage.
I'm not familiar with it. What was it called again? Osteocushion?
Yeah, it's Spring, SPRYNG with osteocushion technology.
No, I'm actually not familiar with that one. So I'll have to go look that up. But there are, there's new things coming out kind of every day that I don't even know about yet. So
Well, then I'm going to sneak in the last question here. So I'm old enough to remember fusing the hock joints by snipping a tendon or ligament. What was found to be harmful about that treatment?
So there is not anything that I know of that we could have just snipped a tendon or ligament to fuse, to cause the hock joints to fuse. So we have to do some sort of destruction to the cartilage to stimulate those to heal. There's not necessarily a tendon or ligament that is preventing that from happening. So most of the time when we're talking about fusing hocks, we getting those distal hock joints to fuse, either facilitating that or getting them to fuse. We're usually talking about drilling across that cartilage to destroy the cartilage and then hope that the bone on bone contact will then go ahead and fuse together. Or we can do things such as alcohol injections. Not my favorite thing to do. And there's some things that I need to do before we would ever inject that to your horse, and make sure that those lower joints don't communicate with that upper joint, because if alcohol were to get in that upper joint of the hock, that would be very, very bad. But so alcohol then would destroy the cartilage cells again in hopes of going ahead to fuse. But I don't know of any in the past, even any tendon or ligament just cutting that would cause the hocks to fuse. So
okay. Well, I think that's it for the questions tonight. Thank you so much, Dr. Young. We'd like to say a special thank you to you for your time, presentation, and insights this evening. And thank you to our many participants that shared thoughtful questions in advance during the presentation. Our Piper Equine Hospital is located on our St. Paul campus and is open for you 24/7. If you enjoyed learning and information provided tonight, we encourage you to visit our website at www.equine.umn.edu, or feel free to reach out to us directly. And lastly, we hope you'll consider supporting our equine program, whether you gift us for clinical outreach, service, education of the next generation of equine practitioners, or towards the advancement of equine research. Its impact makes a difference in the lives of horses and the next generation of our equine practitioners. Thank you again for attending our equine webinar presented by Dr. Young, and enjoy the rest of your evening.